and lidocaine 2.5%. It is known as EMLA, eutectic mixture of local anesthesia. It is available as emulsion in which oil phase is eutectic mixture of lidocaine and pilocaine in the ratio of 1:1 by weight. Supplied as 5 gram or 30 gram tube or as an EMLA disc, can be used to provide surface anesthesia to intact skin. Contraindicated in patients with congenital idiopathic methemoglobinemia. The important part in this is the full form of EML is eutectic mixture of local anesthesia. It is a combination of lidocaine and pilocaine in the ratio of 1:1. It contains 2.5% lidocaine as well as pilocaine 2.5%. And the unique feature of this EMLA is it can be applied even in case of intact skin. You can directly apply over the skin and it has its effect over the deeper tissue. Next is bupivacaine. It is long-acting local anesthetic agent with half-life of 160 minutes due to greater binding capacity to plasma protein and tissue proteins. It is metabolized in the liver, used in oral surgical procedure for its long-lasting pain control, longer onset and longer duration. Its duration effect lasts for 6 to 8 hours. Dose is 1.3 mg per kg. Maximum dose is 90 mg. Available at 0.25 to 0.75% without trading and the concentration of 1:2. In the market, it is available at 0.5% solution in Kathmandu. Now moving to nerve block in maxillofacial region. As you know, in case of maxilla, all the teeth are supplied by the branch of maxillary nerve. There is anterior superior nerve which supplies the central incisor, lateral incisor, canine, its pulp and labial tissue. In case of middle superior nerve, it supplies the buccal tissue of premolars as well as their pulps. And MSA is not present in all the cases. If the MSA is absent, then it is also supplied by ASA. Premolars are also supplied by ASA. If MSA is present, it may supply the major buccal root of first molar as well. And the PSA supplies all the molars, its pulp and buccal tissue, not the palatal tissue. And sometimes in 28% of cases, what happens? The major buccal root is supplied by either MSA or ASA. It is not supplied by PSA. If MSA is present, it is supplied by MSA. If MSA is absent, then a premolar tooth, as well as in 28% of cases of major buccal root of first molar, is also supplied by anterior superior nerve. All of them are branches of maxillary division of trigeminal nerve. If you see the palatal tissue is supplied by the greater palatine nerve. It supplies the palatal gingiva of third molar, second molar, first molar, second premolar up to first premolar. And nasopalatal nerve supplies all the palatal gingiva of anterior teeth, central incisor, lateral incisor, and canine. The one thing you have to remember is, in case of, let's see, if you are planning to extract either canine or premolar, then what happens in this area? There may be presence of cross innervation. Or if you are planning to extract the central incisor, then there may be presence of cross innervation. If you are planning to extract the 1-1 or right side central incisor, those tooth may be supplied by the contralateral side, left side, anterior superior nerve, because some of the nerve fiber may cross the midline and there is cross innervation. So in that condition, what happens? Even if you block the anterior superior nerve, there will still patient will have pain. So in that condition, we have to give either local infiltration or we have to block the contralateral anterior superior alveolar nerve as well. So it usually happens in the teeth which are present in the extreme region, let's say central incisor. In case of right side central incisor, it may be supplied by, there may be presence of cross innervation from the left side, but it does not happen with lateral incisor. Okay. Similarly, in case of canine or first premolar, what happens? In case of first premolar, till first premolar, it is supplied by greater palatine nerve, and up to canine, it is supplied by nasopalatine nerve. But due to cross innervation, either tooth may be supplied by both the nerve. Okay, the premolar may be there. In case of premolar palatal gingiva, it may be premolar gingiva is may be supplied by nasopalatal nerve as well as the palatal gingiva in the region of canine can be supplied by the greater palatine nerve also. So you have to be careful in these tooth. If patient has still pain, you have to block the other nerve as well, or you can give the local infiltration. It's always better to do the nerve block because nerve block is more effective. Patient will have no pain. In case of if you give the infiltration in palatal gingiva, it is firmly adhered to the bony structure, so there is no space, no any available space for the accumulation of or for the deposition of local anesthesia. So patient will have sharp pain. So it's always better to do the nerve block instead of local infiltration. On the case, in case of geriatric patient, the bone is compact. Okay, even if you deposit a local anesthesia in the region of apex of the tooth or in the region of other area, the local anesthesia could not cross the bone because there is a presence of compact bone. The local anesthesia could not diffuse and reach to the root. So patient will still have pain. So it's always better to do the nerve block instead of giving local infiltration. In case of pediatric patient, young patient, no problem. Even if you give the local infiltration, it will work. But in case of a geriatric patient, old age patient, due to presence of compact bone, the local anesthesia will not diffuse to the tissue into the deeper tissue, and patient will have pain. The anesthesia will not work. So it's always better to give the nerve block. Okay. As compared to all the nerve block, the most painful nerve block is nasopalatine nerve block, followed by greater palatine. The least painful is PSA, posterior superior nerve block, because there is presence of only soft tissue. You don't have to contact the bone. So deposition of local anesthesia in the soft tissue is comparatively easy. So sensory innervation of a teeth. In case of mandibular teeth, all the mandibular teeth are supplied by inferior nerve. Inferior nerve supplies the pulp tissue of all the teeth as well as buccal gingiva of premolar and anterior teeth. Only the buccal gingiva of molars are supplied by long buccal nerve, and all the lingual tissue are supplied by lingual nerve. Similar in case of maxilla, the anterior tooth are supplied by anterior superior nerve. Premolars are supplied by medial superior nerve. If it is absent, then it is also supplied by the ASA. In case of posterior molar tooth, it is supplied by PSA. So types of nerve block: in case of maxilla, there is posterior superior nerve block, MSA, ASA, greater palatine block, infraparietal block, and nasopalatine block. In case of mandible, it can be inferior nerve block, buccal nerve block, mental nerve block, incisive block, Boger's mandibular nerve block, mandibular block, extraoral approach. In case of maxilla, you can also directly block the whole of the maxillary branches. You can directly block the maxillary branch of trigeminal nerve. It is also there are two types. Either you can approach through the greater palatine foramen. You have to insert the needle from the greater palatine foramen, and you have to reach to the pterygomaxillary fissure, or you can approach through the buccal sulcus in the region of 7. In case of PSA, you have to penetrate about 16 mm. But in case of, if you want to give the maxillary nerve block, you have to penetrate till 25 mm. So there is something called local infiltration, field block, or nerve block. What happens in case of local infiltration is, it is a type of injection that anesthetizes a small area, 1 or 2 teeth and associated areas. Anesthesia is deposited at nerve terminals. That is important. In case of local infiltration, local anesthesia is deposited in the region of nerve terminals. In case of field block, local anesthesia is deposited near large terminal nerve branches. Anesthetized area will be circumscribed. In case of nerve block, it is a type of injection that anesthetizes a large area. Anesthesia is deposited near the large nerve branch. The difference between these three is, in case of local infiltration, local anesthesia is deposited at nerve terminals. In case of field block, it is deposited at terminal nerve branches, as shown in figure. In case of nerve block, whole of the bundle is anesthetized simultaneously. Anesthesia is deposited near large nerve trunks. के को लागि आजबाट जोइन गर्नुभएको हजुर यही बस्नु In case of maxillary nerve block, posterior superior nerve block is supplied. All nerve block is recommended for maxillary molar teeth and associated buccal tissue in one quadrant. In case of MSA, it is recommended for maxillary premolars and associated buccal tissue. In case of ASA, it is recommended for maxillary canine and incisor in one quadrant. Greater palatine block, it is recommended for palatal tissue distal to maxillary canine in one quadrant. Similarly, nasopalatine block is recommended for palatal tissue between the right and left maxillary canines. There is also maxillary nerve block. There are two approaches: high tuberosity approach and greater palatine approach. So in case of PSA, posterior superior alveolar nerve, it supplies to the pulp tissue of first, second, and third molar as well as buccal gingiva. Okay, except major buccal root. In case of 28% of cases, it may be supplied by either MSA or ASA. So while giving a PSA block, you have to insert the needle through the buccal vestibule of 7. you have to penetrate by about 16 mm. The bevel should be towards the bone. You have to penetrate 16 mm. You have to aspirate in two directions. First, you have to aspirate. If it's negative, rotate the syringe by 90 degree. Again, you have to aspirate. If it is negative, then you can deposit about 1.8 ml of local anesthesia. And the rate of deposition is, it should be slow. It is, what is the rate of deposition of local anesthesia? It is 1 ml per minute. Okay, it has been asked many times. In case of all the nerve block, while you are giving either local infiltration or nerve block, the rate of deposition of local anesthesia is 1 ml per minute. In case of PSA, you have to deposit 1.8 ml of local anesthesia in the infratemporal fossa. You have to inject through the buccal vestibule with respect to second molar tooth. The angulation should be posterior, medial, and superior. It should make an angle of 45 degree with all the x-axis, y-axis, and z-axis. The depth of penetration should be 16 mm. The most common complication associated with PSA nerve block is there will be rupture of pterygoid venous plexus, and it will lead to formation of hematoma. What will you do if there is rupture of pterygoid venous plexus and the hematoma is formed? How will you manage that case? At first, as soon as you know that there is pterygoid venous plexus ruptured, there is formation of hematoma, you have to give pressure. And always in case of PSA block, in case of pterygoid venous plexus, once the pterygoid venous plexus is ruptured, you have to apply pressure in the buccal vestibule, never extraorally, because there is presence of zygomatic arch. So you have to apply the pressure intraorally in the buccal vestibule. Okay. So give pressure pack for 5 minutes, then you have to observe. If the hematoma is small, then you don't have to worry. Just you have to prescribe the antibiotic, because what happens, as you know, the blood is a good culture media for the growth of bacteria. So there may be chances of infection. To prevent the infection, you have to prescribe the antibiotic. Okay. If the hematoma is small, if the hematoma is large, then no doubt you have to give incision. You have to drain the hematoma. If you leave as it is, it will be calcified and it will produce permanent facial deformity. It will lead to facial asymmetry. There will be large, huge swelling. So it depends on size. If it is small, it will heal by itself. You don't have to worry. If it is large, the hematoma should be drained through intraoral approach. You have to give the vestibular incision and you have to drain the hematoma. Next is MSA, middle superior nerve block. It supplies the two premolar teeth, its pulp, buccal gingiva, as well as major buccal root of postmolar. Okay. MSA may not be present in all cases. If MSA is absent, then it is also supplied by anterior superior and superior alveolar nerve block. If you want to block the MSA, then you have to approach through the second premolar tooth. If you want to block the ASA, then you have to approach to the first premolar tooth. Along the long axis of the tooth, you have to reach to the infraorbital foramen. Once the infraorbital foramen, you reach the infraorbital foramen, you have to aspirate. If it's negative, rotate the needle by 90 degree. Again, if the aspiration is negative, then you have to deposit about 1.2 ml of local anesthesia in the infraorbital region. Okay. When you give the when you deposit the local anesthesia in the infraorbital region, what will happen? The local anesthesia will diffuse into the infraorbital foramen. It will block the ASA. And the subjective symptoms will be, as soon as you deposit local anesthesia in the region in the infraorbital area, the terminal branches of infraorbital nerve are inferior palpebral, lateral nasal, as well as superior labial branches. So these nerves will also get anesthetized. So the patient will feel numbness over the upper lip, lateral part of nose, as well as lower eyelid. Okay, so that is the subjective symptoms of in case of infraorbital nerve block or ASA nerve block. So what is the subjective symptoms in case of PSA? No symptoms. PSA do not have any subjective symptoms because PSA do not supply any of the outer structure. Okay. In all other nerve block, there are subjective symptoms, but in case of PSA, there is no subjective symptoms. Okay. So when you deposit local anesthesia in the region of infravital area, it will block from the central incisor to the major vocal root of first molar. Now the question, if you want to extract the first molar tooth, which block do you give? You have to give PSNR block as well as greater palatine, and for major vocal root, you have two options. Either you can give local infiltration, or you have to you have to deposit local anesthesia in the region of infravital. So you have to do MSA block or ASA block. So another question frequently asked is, when you deposit local anesthesia in the region of major vocal root of first molar, it will not work. Most of the time, it is not efficient. Why? What is the reason? In the region of first molar, when you give local infiltration, usually it is ineffective, not effective, inefficient. Because what happens in the region of first molar, when you give local infiltration to block the major vocal root, there is a presence of zygomatic buttress, thick zygomatic bone is there. So whenever you deposit local anesthesia in this area, due to presence of thick bone, local anesthesia could not diffuse and reach to the root of the tooth. Okay, that's why the local infiltration is not effective if you give local infiltration in the region of first molar. So in that cases, you have to do NOR block. And it is common in case of geriatric patient, because in case of geriatric patient, old age patient, bone is compact and the local anesthesia could not diffuse and transmit through the bone and reach to the root or periodontal ligament. So it is also asked why local infiltration is not effective in the region of first molar, because due to the presence of thick bone, due to the presence of zygomatic buttress over the root of the first molar, the local anesthesia could not diffuse to the deeper structure and it is inefficient. So objective symptoms is there is numbness over the upper lip, lateral part of the nose, as well as lower eyelid, because it also simultaneously blocks the superior labial branch, lateral nasal branch, and inferior palpebral branch of. These are the terminal branches of infraorbital nerve. So you have to approach through the first premolar tooth. Next is greater palatine block. Greater palatine nerve supplies the palatal gingiva of all the posterior teeth, premolars and molars. You have to approach on the palatal gingiva about 1 centimeter medial to the marginal gingiva at the junction of second and third molar, about 1 centimeter medial to the junction of second and third molar. At the junction of horizontal part of hard palate and vertical part of hard palate, you have to hit that area. And you are giving the greater palatine nerve block, the needle should be perpendicular to the palatal tissue. So you have to approach at the junction of horizontal part of hard palate and vertical part of hard palate about 1 centimeter medial to the marginal gingiva from the junction of second and third molar, not first and second molar. From the junction of second and third molar, there is interdental papilla. You have to approach 1 centimeter medial to this marginal gingiva. At the junction of horizontal part and vertical part of hard palate, and the needle should be perpendicular to the palatal tissue. So you have to approach from the contralateral side of oral cavity, from the opposite corner of the mouth. And you have to aspirate. And if it is negative, then again you have to rotate the needle by 90 degrees. Again you have to aspirate. Again, if it is negative, then you have to deposit about 0.45 to 0.6 ml of local anesthesia for greater palatine nerve block. So this is the area. There is presence of greater palatine foramen. You have to reach this greater palatine foramen because the neurovascular bundle exits through this foramen and you have to block this nerve. And this greater palatine foramen is present just medial to second and third nerve. So you have to inject local anesthesia about 1 centimeter medial to the junction of second and third molar tooth. Our target is this greater palatine foramen. And what happens is there is always the nerve is associated with artery and vein. The chances of rupture of blood vessels is very high, so you have to aspirate. Next is nasopalatal nerve block. Nasopalatal nerve supplies the palatal gingiva of all the interior teeth, central, lateral, and canine. So if you want to do any procedure over this palatal gingiva, or if you want to extract those teeth, then you have to do the nasopalatal nerve block. For that, you have to deposit local anesthesia in the incisive papilla. In soft tissue, there is incisive papilla. Okay, and the difference between this nasopalatal nerve block and other nerve block is, while you are giving other nerve block, the bevel of the needle should always face towards the bone. But in case of nasopalatal nerve block, the bevel of the needle is facing towards the soft tissue, because in this area the palatal gingiva is firmly adhered to the bone. So it's very difficult to deposit local anesthesia in this area. That's why this nerve block is the most painful among all the nerve block, because there is no any space present in the palatal gingiva. And our target is nasopalatal foramen, incisive foramen. Okay, so you have to deposit about 0.3 to 0.45 ml of local anesthetic agent. And clinically, if you see blanching, it indicates that you have already deposited local anesthesia. Once the blanching is present, then it will be easily anesthetized. Next is maxillary nerve block. You can directly block all the division of maxillary nerve. Maxillary nerve is the second division of trigeminal nerve. So maxillary nerve block is effective method of achieving profound anesthesia of hemi-maxilla. Half of the maxilla will be anesthetized simultaneously. There are two approaches. One is high tuberosity approach, and other is a greater palatal foramen approach. In case of high tuberosity approach, area of insertion is height of mucobuccal fold above the distal aspect of maxillary second molar. It's similar to PSA nerve block. Okay, height of mucobuccal fold just above the distal aspect of maxillary second molar. Target area is maxillary nerve as it passes through the pterygopalatal fossa. This is the pterygopalatal fossa. Posteriorly there is presence of pterygoid plate, anteriorly there is presence of maxillary bone. This is known as pterygomaxillary fissure or pterygopalatal fossa. Okay. Landmarks are mucobuccal fold distal to maxillary second molar, maxillary tuberosity, zygomatic process of the maxilla. Direction is again upward, inward, and backward. It's similar to PSA block. So only the difference is depth of penetration. In case of PSA block, the depth of penetration is only 16 mm. So be careful. If you insert your needle more than 16 mm, the probability of rupturing the pterygoid venous plexus is very high, and it will lead to formation of hematoma. But in case of, if you want to block the maxillary nerve, the depth of penetration should be 25 to 30 mm. The area is same, but the depth of penetration is 25 to 30 mm because you have to reach this pterygopalatal fossa area. Okay. Other approaches through the greater palatal canal approach, area of insertion is over greater palatal foramen. Target area is maxillary nerve. Needle pass through greater palatal canal to pterygopalatal fossa. You have to directly insert your needle through this greater palatal foramen, and you have to reach the pterygopalatal fossa posteriorly within the bone. Landmarks are greater palatal foramen, junction of maxillary process and the palatine bone. Locate greater palatal foramen, advance the needle from the opposite side to reach to 40 mm depth. And be careful, you may break your needle, so you have to be careful. Signs and symptoms are: subjective symptoms are pressure behind upper jaw followed by numbness of lower eyelid, upper lip, and side of nose. Objective symptoms will be there is no pain. In case of objective symptoms, in all the nerve block, there will be no pain. That's all. Complications are hematoma due to maxillary artery puncture, penetration into orbit may occur in greater palatine approach, periorbital swelling and proptosis, diplopia due to regionally blocking abducens nerve, optic nerve block causing transient vision loss, greater pulmonary hemorrhage, penetration into nasal cavity. If you penetrate into the nasal cavity, then if needle deviates to medial side during insertion through greater palatal canal, then on aspiration, large amount of air will appear in the syringe, and on injection, patients complains that local anesthesia solution is running down the throat. In case of mandibular block, infiltration is not as successful as maxillary anesthesia because due to presence of compact bone in case of mandible. So local infiltration is usually ineffective in mandible as compared to maxilla. Because in maxilla, the bone is thin, it is porous, so local infiltration is effective. Another factor is age factor. In case of geriatric patient, usually local infiltration doesn't work. So substantial variability in anatomy of landmarks when compared to the maxilla. The techniques in case of mandibular nerve blocks are either inferior nerve block, buccal nerve block, mental nerve block, incisive nerve block, Go-Getz technique, Vazirani kinetic closed mouth technique, or extraoral mandibular nerve block. Okay. In case of mandible, if you give the inferior nerve block, you simultaneously blocks all the tooth, because the inferior nerve supplies the pulp tissue of all the mandibular teeth, as well as it supplies the buccal gingiva or labial gingiva of premolars and anterior teeth, central incisor, lateral incisor, canine, first and second premolars, its buccal gingiva or labial gingiva, as well as the pulp of this premolar, molar, anterior teeth, all are supplied by inferior nerve. So when you give the inferior nerve block, all the PC will get anesthetized simultaneously. So most commonly used in dentistry may be combined with a buccal block. Variability in the location of the mandibular foramen on the ramus can lessen the success of this injection. Failure rate is 15 to 20%. So while giving the inferior nerve block, you have to deposit the local anesthesia in the region of mandibular foramen, because the inferior nerve enters through the mandibular foramen and it will exit through mental foramen. In the region of mental foramen, the inferior nerve divided into two parts. The mental nerve comes out of mental foramen, and on the branch is incisive nerve. The incisive nerve supplies the anterior tooth, and mental nerve supplies the labial gingiva as well as labial vestibule. So while giving the inferior nerve block, you have to palpate the sigmoid nerves. You have to deposit the local anesthesia in the region of mandibular foramen. So ideally, you have to be about 6 to 10 mm above the occlusal level and at the junction of anterior 2/3 and posterior 1/3. So anterior posteriorly, you have to reach at the junction of anterior 2/3 and posterior 1/3 in this area, and it should be about 6 to 10 mm above the occlusal level, so that you can deposit local anesthesia in this area in the region of mandibular foramen when the inferior nerve enters inside the mandible through this mandibular foramen. So pterygomandibular raphe, the pterygomandibular raphe originates from the hamulus of pterygoid plate, and it is inserted into the posterior, superior, and medial part of retromolar pad. So this pterygomandibular raphe, also there is insertion of anteriorly there is attachment of Vasoconstrictor muscle, and posteriorly there is attachment of superior pharyngeal constrictor muscle. You have to insert your needle anterior to this pterygomandibular raphe. So while giving inferior nerve block, your needle penetrates the Vasoconstrictor muscle, not the medial pterygoid. It is also asked while giving inferior nerve block, which muscle is penetrated. It's not medial pterygoid, though medial pterygoid muscle is present medial to the ramus of mandible, but while injecting local anesthesia in case of inferior nerve block, you have to approach through the anterior region from the opposite corner of the mouth, opposite premolar tooth. So you have to penetrate through the Vasoconstrictor muscle and you have to reach the pterygomandibular space, and local anesthesia is deposited in the region of pterygomandibular space. So clinically, you have to palpate the sigmoid nerves, you have to hold the mandible, you have to put your index finger and forefinger posteriorly towards the posterior border of the ramus of mandible. Anteriorly, the thumb should be placed at the sigmoid nerves. Then you have to insert your needle at the junction of anterior 2/3 and posterior 1/3, and it should be about 6 to 10 mm above the occlusal level. And you have to instruct the patient to open his mouth wide. So this is the target area. It should be at the junction of anterior 2/3 and posterior 1/3, and about 6 to 10 mm above the occlusal level. If your needle goes more posteriorly, then what will happen? Because you can't see anything clinically, you have to assume, you have to imagine. What will happen if your needle goes more posteriorly? It will enter into it will enter into parotid space, because there is presence of parotid gland. Parotid gland has two lobes. One is present superficially, and the small lobe is in the deeper structure posteriorly. So when your direction is not correct, if your needle enters more posteriorly, you will enter into the parotid space. If you deposit local anesthesia within the parotid space, then what will happen? The local anesthesia will be deposited within the parotid gland, and there is presence of all the terminal branches of the facial nerve. So there will be facial nerve paralysis. Okay. What will you do if there is facial nerve paralysis? Luckily, fortunately, it's temporary. Okay. Patient will be asymptomatic after a few hours, after 3 to 4 hours, because the effect of local anesthesia in soft tissue is only 3 to 5 hours. So after 3 to 5 hours, it will be normal. You don't have to worry. You don't have to do anything. Just assure the patient. Okay. What will happen if your injection, the direction of injection is more anteriorly? There will be early hitting of bone. You will already hit this buttress. So you have to again change your direction. You have to insert posteriorly. And once you hit the bone, until and unless bone is hit, you don't deposit local anesthesia. Once you hit the bone, then you have to aspirate. If it is negative, again turn your needle by 90 degree, rotate your needle by 90 degree, again aspirate. If it's negative, then you have to deposit about 1.5 ml of local anesthesia in the region of mandibular foramen, and the rate of deposition is again 1 ml per minute. Okay, while injecting local anesthesia, patients usually have burning pain, burning sensation. Why? What is the reason behind that? In case of any nerve block, even if it is local infiltration, patient will complain of having burning pain. Especially in case of if the local anesthetic is, if it is local anesthesia with adrenaline, not a plain local anesthesia. What happens is in case of local anesthetic vial, if it is mixed with adrenaline in the dilution of either 1:2,000 or 1:2 lakh, its pH is less, about 4 to 5. So due to its low pH, when you deposit local anesthesia, there is burning pain due to acidic nature of the local anesthesia. Next is long buccal nerve block, or it is also known as buccal nerve block. When you are planning to do any surgery in the molar region, if you are planning to extract the impacted tooth or first or second molar, you have to give buccal nerve block as well. For buccal nerve block, you have to insert your injection just distal and buccal to last erupted tooth, whether it is second molar or third molar. If the third molar is erupted, you have to insert your needle at the anterior border of the ramus, just distal and buccal to the third molar or second molar. That is the last erupted tooth. If it is second molar, then you have to insert buccal and distal to second molar. If it is third molar, then you have to approach the needle just distal and buccal to the second molar. So you have to hit the interior border of the ramus, and once you hit the interior border of the ramus, you have to aspirate again. If it is negative, rotate your needle by 90 degree. Again, you have to aspirate. If it's still negative, then you have to deposit your local anesthesia about 0.5 to 0.6 ml. And always deposition of local anesthesia should be slow. It should be about 1 ml per minute. So target area is in this region, anterior border of the ramus, just distal and buccal to the last erupted tooth. Clinically, you have to palpate anterior border of the ramus. You have to approach your needle just distal and buccal to the last erupted tooth. Once you have hit the interior border of the ramus of mandible, then aspirate, turn your needle by 90 degree. Again, you have to aspirate, then deposit about 0.5 to 0.6 ml of local anesthetic agent. Next is mental nerve block. If you are planning to do any surgery, usually if you are planning to enucleate the mucocil from the lower lip, then you can give the mental nerve block. So mental nerve is usually present in the apical region of the second premolar teeth most of the time. So you have to palpate in the region of palpate the mental foramen in the region of second premolar. Even if you can't palpate due to presence of muscles in this area, just you deposit local anesthesia in the region of second premolar or at the junction of first and second premolar. You can deposit about 0.5 ml of local anesthesia, and there will be numbness over the lower lip. And you can do any procedure in the labial vestibule anterior to the premolar tooth central incisor. Next is incisive nerve block. You can also give incisive nerve block, though clinically it's not important because you can directly block the inferior nerve block. It's easy. But if you want to give the incisive nerve block while injecting with the local anesthesia to block the incisive nerve, mental nerve will also get blocked because both are not divided at the same point. Inferior nerve divides into two parts, incisive nerve and mental nerve in the region of mental foramen. The mental nerve exits through the mental foramen and it supplies the labial gingiva as well as labial mucosa of the lip and cheek. And incisive nerve supplies the pulp tissue of anterior teeth as well as premolar. So when you give deposit local anesthesia in the mental foramen, when you give the incisive nerve block, mental nerve block will also get anesthetized. So for incisive nerve block, you have to insert your needle through the mental foramen. You have to enter inside. Once you have penetrated your needle through the mental foramen, then you have to deposit local anesthesia to block the incisive nerve. Next is Go-Gets technique. It is also known as open mouth technique to block the mandibular nerve. All the division of the mandibular nerve can be anesthetized simultaneously. In 1973, George Albert Edward Goget's general dental practitioner described this technique. It is a true mandibular nerve block. Anesthetize usually entire third branch of trigeminal nerve or inferior nerve, lingual, mylohyoid, mental, incisive, auriculotemporal, and buccal nerve. So all the branches of mandibular nerve are anesthetized simultaneously with a single block. Success rate is more than 95%. Area anesthesia, mandibular teeth to midline, buccal mucoperiosteum, anterior two-third of tongue and floor of mouth on ipsilateral side, body of mandible, inferior ramus, as well as skin over the zygoma, posterior portion of cheek, and temporal region. So area of insertion is mucous membrane on the mesial of ramus on a line from intertragic nose to corner of mouth, just distal to maxillary second molar tooth. You have to draw a line from the corner of mouth to intertragic nose, and you have to insert your needle in this line. And always, while giving the Goget's technique, clinically you can't visualize the inner structure, so you have to approach the needle just below the mesial-palatal cusp of second molar tooth from the contralateral side. Target area is lateral side of condylar neck, just below the insertion of lateral pterygoid muscle. So bone contact is a neck of condyle, and depth of penetration is 25 mm. Okay. Clinically, when you approach from the opposite side of the mouth, from the opposite corner of the mouth, you have to approach your needle just below the mesial-palatal cusp of the second molar, and you have to penetrate your needle by 25 mm. Then you will reach the neck of the condyle. Once you hit the neck of the condyle, then aspirate, and you have to deposit the local anesthesia, and you can block all the branches of mandibular nerve. Next is Vazirani echinosis closed mouth technique. Clinically, it is very important because in case of trismus, if the patient could not open the mouth, and if you have to do any procedures, then you can block all the division of mandibular nerve through this technique. Okay, in 1977, Dr. Joseph Echinosi reported the closed mouth approach to mandibular anesthesia. It is primarily useful in case of trismus. In 1992, Wolfe described the modification of Vazirani echinosis technique of 45-degree bending of needle. So it anesthetizes all the branches of mandibular nerve. Area of anesthesia are mandibular teeth from last molar to midline, buccal mucoperiosteum, body of mandible, and inferior ramus, anterior two-third of tongue, and floor of mouth on ipsilateral side. So in this technique, what happens? If the patient could not open the mouth, you have to approach the needle through the buccal vestibule, and your syringe should be parallel to the occlusal plane, and you have to hit the neck of the condyle. Okay. So you have to approach through the buccal vestibule in the maxilla. Your syringe should be parallel to the occlusal plane, and you have to reach near the neck of the condyle where mandibular nerve exits. So this is the area you have to approach through the maxillary buccal vestibule. You have to reach. The most important thing is that your syringe should be parallel to the occlusal plane, and you have to hit the neck of the condyle. In this area, you have to deposit the local anesthetic agent, and you block all the branches of mandibular division. And especially, it is important in case of buccal space infection, or if there is any space infection, if the patient could not open the mouth, if the patient has trismus, in that case, you can block the mandibular nerve and you can do your surgery. Under is mandibular nerve block, extraoral approach, nerve anesthesia, mandibular nerve and its branches. Target area is foramen ovale, because you know the mandibular nerve exits through the foramen ovale. There are three branches of trigeminal nerve, right? Ophthalmic division, maxillary division, and mandibular division. Ophthalmic division exit through superior orbital fissure. Maxillary division through foramen rotundum, and mandibular division through foramen ovale. So as soon as it exits through the intercranial fossa through the foramen ovale, you have to deposit your local anesthesia in the region of foramen ovale. So all the branches of the mandibular division will be blocked or anesthetized simultaneously. Point of entry is skin over the sigmoid nerves, 20 or 22 gauge, 3 to 5 inch. Spinal needle is needed. Spinal needle is very long needle, and you have to approach through just anterior to 3 mg area in the depth of the sigmoid nerves. Indication are infection and acute inflammation, presence of trauma, which contraindicate the use of mandibular block, where there is need to anesthetize entire mandibular nerve, diagnostic and therapeutic purpose, and extensive surgical procedure with single penetration and minimum local anesthesia. Anatomical landmarks are midpoint of zygomatic bone, coronate process of ramus of mandible, prominence of lateral pole of condyle, which is located by having patient open and closed mouth and lateral pterygoid plate. Technique is prepare skin overlying a sigmoid notch, anesthetize skin and masseter muscle, then pass a spinal needle through sigmoid notch until pterygoid plate is contracted. Once the needle contracts the lateral pterygoid plate, then withdraw with only the point left in the tissue and redirected in slight forward and upward direction posteriorly towards foramen ovale. Remove the stylate and place filled syringe on a spinal needle and aspirate and deposit about 3 mm local anesthesia. Clinically, it's very difficult because the masseter muscle is attached just below the zygomatic arch. From the zygomatic arch to lateral border of lateral surface of ramus of mandible, there is presence of thick masseter muscle. So you have to penetrate through the muscle. You have to approach through the sigmoid notch. You have to hit the pterygoid plate. Once the pterygoid plate is hit, you hit the pterygoid plate. You have to again change your direction. The chances of needle breakage is very high. So clinically, it's difficult. So this is the area you have to approach just above the sigmoid notch through the masseter muscle, just interior to the PMJ area. Once the pterygoid plate is hit, you have to change your directions anteriorly and superiorly, and you have to reach the foramen ovale. Okay. And this, while giving the extraoral block for mandibular knot block, you have to use a spinal needle, not those common cartridge or disposable syringe, because those needles are small. You can't penetrate through this area, and chances of breakage is also high. So you have to use the spinal needle. The spinal needle is long and it is strong enough; it will not break. General complication of local anesthesia. There are local complication and systemic complication. In case of local complication, if there may be needle breakage, what will you do if your needle breaks while injecting local anesthesia? If some part of the needle is visible, then just you can hold it with any instrument and you can withdraw. If it is within the tissue, then you have to do surgery. You have to open the area, explore the area, and you have to remove the needles. So before that, you have to do either CT scan or plain X-ray. You have to locate the needle. Once you locate the needle, then you have to explore surgically. So it is said that whenever you are injecting any local anesthesia, you should not penetrate your needle completely. Okay, some of your part of the needle after hub should be visible, because it is seen that most of the time when your needle breaks, it is broken at the junction of hub and the needle. Okay, it breaks from the hub area. Do you know the hub where you join your needle with the syringe? So never try to penetrate the needle completely till the hub. Some of the needle must be visible. Even though if it breaks, you can retrieve your needle easily. There may be chances of persistent anesthesia if the nerve is traumatized. There may be trismus. Usually, trismus is associated with infibullar nerve block due to either fibrosis. If you deposit your local anesthesia within the medial pterygoid muscle, it leads to fibrosis. Once there is fibrosis, the patient could not open the mouth. It will lead to trismus. And the treatment is you have to advise the patient to do physical exercise. You have to advise the patient for mouth opening exercise, even though it's painful, but they have to do. And rehabilitation should be done as soon as possible. Another complication can be hematoma. The most common complication of PS is hematoma. Hematoma is usually associated with PSA nerve block, but it may be present in case of even though if you give the mental nerve block or infravital nerve block or IAMP. So whenever there is hematoma, if it is small, then you don't have to worry, especially if it is present if it is visible through the skin. In case of mental nerve block or infravital nerve block, if there is presence of hematoma, then just prescribe the antibiotic. It takes around 2 to 3 weeks time. What will happen? Initially, it is brownish black in color. Slowly, it will change into yellowish color. Then again, the skin will change to normal color, because all the hemoglobin which are present is converted into hemosiderin, and hemosiderin appears as yellowish in color. So through normal metabolism, it will be metabolized. You don't have to do anything. But it will take times 2 to 3 weeks. It will take 2 to 3 weeks time. You have to assure the patient it is normal phenomenon, and it will be dissolve itself. The color will change to yellowish color, then again it will change to normal skin color. Due to presence of hemosiderin, the skin appears as yellowish. If the hematoma is large, there is a huge accumulation of blood, large amount of blood is accumulated. In that condition, you have to drain the hematoma. you can't leave as it is, because in case of large hematoma, it may lead to calcification, it will lead to heart swelling. So you have to drain the hematoma if it's large. Pain and injection is due to when you deposit the local anesthesia, there is splitting of soft tissue. When the soft tissue is split, there will be sharp pain. So you have to deposit the local anesthesia slowly. The rate of deposition should be 1 ml per minute. Burning and injections is due to, especially if the local anesthesia is mixed with adrenaline. If the local anesthesia contains adrenaline, the pH of that local anesthesia is less, about 4 to 5. So due to the low pH or acidic environment, patient will have burning sensation. You can't do anything for that. Infection, always you have to follow the sterile technique. Never try to toss the needle with gloves because it is already sterilized. Okay. And while giving any injection, you have to advise the patient to gargle with betadine or chlorhexidine. So it will decrease the bacterial load in the oral cavity. Especially in case of surgery, if you are planning to do any surgery in the oral cavity, you have to advise the patient to gargle with chlorhexidine 0.2%. So ischemic complication can be adverse drug reaction, overdose, or allergy. Allergy is usually associated with sterile local anesthetics, and it is less common with amide. So another complication can be facial nerve paralysis when you are giving the inferior nerve block. If the direction is not proper, if you go more posteriorly, you will enter into the parotid space. Once you enter the parotid space, there is presence of parotid gland, and within the parotid gland, there is presence of facial nerve, and it's where the facial nerve divided into 5 terminal branches: temporal, buccal, maxillomandibular, and cervical branches. So in this case, while giving the left side inferior nerve block, it has entered into the left parotid space, and once the local anesthesia deposits into the parotid space, it leads to anesthesia. It anesthetizes the left side of facial nerve. So patient could not close the mouth, could not do fawning. The fawning is due to the muscles of forehead is supplied by which branch? It's due to temporal branch. Here the temporal branch is not working. That's why there is fawning is present on the right side, but it is left side. You can see it is blank. Similarly, the eyes, the extraocular muscles of eye or orbicularis oculi is supplied by zygomatic branch. So again, the zygomatic branch, it is normal on the contralateral side, but patient could not close the mouth on the same opposite side or the affected side. So this is the case of temporary facial nerve paralysis on left side. While injecting local anesthesia, while blocking the inferior nerve, if the direction is not proper, if you go more posteriorly, you will enter into parotid space, and it may lead to facial nerve paralysis. But fortunately, luckily, it's temporary. Within few hours, it will be normal. You don't have to worry. You don't have to do anything. Next complication is soft tissue injury, especially in pediatric tissue. What will happen if you extract the teeth and if you give the inferior nerve block or infiltration, the lips are anesthetized, and the pediatric patient will bite the lip and it will lead to soft tissue trauma. This is the traumatized lip caused by inadvertent biting while it was still anesthetized. So either you have to instruct the parents, or you can put this cotton roll placed between lips and teeth, secured with a dental floss, minimize the risk of accidental mechanical trauma to anesthesia. On the hematoma, it is due to mental nerve block. While giving the mental nerve block, the mental vessels are being ruptured, and there is accumulation of blood within the soft tissue, and especially it is present in the old age patient, because the connective tissue which are present within the soft tissue are loose and they can hold more amount of blood. And if there is hematoma, just prescribe antibiotic, because in case of hematoma, as you know, the blood is a good culture media for bacteria, so the chances of infection is high. In order to prevent the infection, you have to prescribe the antibiotic for at least 5 days. And again, it will be converted to yellowish color and then into normal skin color. The body itself metabolizes those hematoma. You don't have to do anything. If the hematoma is large, then no doubt you have to drain the hematoma. Needle breakage. Breakage of needle with soft tissue is uncommon, but can happen due to weakening of dental needle by bending or sudden unexpected movement of a patient. So retrieval, if fragment is visible, removed by a small hemostat or Magill forceps. If some part of the needle is visible, you can just hold it with using either needle holder or artery forceps. If needle is not visible, surgical intervention may be needed with radiological assistance. First, you have to take the radiograph, you have to identify the needle, then you have to explore surgically. Trismus, it may be post-injection trismus is due to either alcohol present in local anesthesia, hemorrhage, low-grade infection, trauma to muscle, and multiple needle penetration. So management is heat therapy, warm salines, analgesics, and muscle relaxant. And most important is physiotherapy, mouth opening exercise. Now, toxicity of lignocaine. If the lignocaine enters into the blood, then it may have anticonvulsive effect, or it may show sign of pre-seizure, or there may be presence of tonic-clonic seizure. So it depends on the concentration of local anesthesia or lignocaine in blood. If the concentration is between 0.5 to 4 microgram per ml, it will have anticonvulsive effect. If the concentration rises to 4.5 to 7 microgram per ml, then there will be sign of pre-seizures. And if it is more than 7.5, there will be tonic-clonic seizure. So in the central nervous system, as you know, the local anesthesia has an effect on respiratory system, cardiovascular system, and central nervous system. In the respiratory system, it causes depression. In cardiovascular system, also it causes suppression of cardiovascular system, but in CNS, it has a dual effect. Initially, it has excitatory effect, on later, it will have depression effect. It has both the effect in central nervous system. It's unique. So it is asked multiple, it has already asked many times in exam. So what happens is normally in the brain, there is some supply of inhibitory impulses as well as facilitatory impulses there. Initially, what happens, the local anesthesia will inhibit or block the inhibitory impulses. So the facilitatory impulse will be there. So it will lead to pre-seizure symptoms, or it may lead to seizure. Okay. Later, what happens? There initially, once all the inhibitory impulses are not blocked, then it will lead to pre-seizure signs and symptoms. Once all the inhibitory impulses are blocked, then what will happen? Only the facilitatory impulse are there. So due to the presence of this facilitatory impulse, there will be seizure, tonic-clonic attack. Once again, in later case, if the concentration of local anesthesia is more in the brain, then in late case, it will inhibit both the inhibitory impulses as well as facilitatory impulses. So there will be generalized CNS depression. So initially, it has excitatory effect. In later case, there will be generalized CNS depression. You have to know the sequence. Initially, there will be excitation followed by generalized depression. In the CNS, it has both the effect. Unlike respiratory system or cardiovascular system, in both the respiratory system and cardiovascular system, it has respiratory depression as well as cardiovascular system suppression effect. So preconvulsive signs and symptoms are slurred speech, shivering, muscular twitching, tremor of muscles of face and distal extremities, generalized lightheadedness, dizziness, visual disturbances, inability to focus, auditory disturbance, drowsiness, disorientation. Also, there will be numbness of tongue and circumoral region, warm, flushed feeling of skin, and pleasant dream-like state.